Welcome back everyone. I hope you all enjoyed your lunch. We now have a session on the genito-urinary tract. I invite our chairpersons, Dr. Nadrajan, Senior Consultant Radiologist, Kadalur, Dr. Ankur Shah, Consultant Radiologist, Sadbhav Imaging Center and GIC Prime, and Dr. Kuparajan, Consultant Urologist, KMCH, who will join us in a few minutes. The first speaker for the afternoon session will be on current recommendations for imaging adrenal lesions. I welcome on stage Dr. Shivakumar Swami. Over to you, sir.
Thank you, everyone. If I overshoot in the interest of time, you can stop me, chairpersons, anytime. I just want to start with a few of the cases. We can go back to these cases at the end of the tail end of the talk. Again, non-enhanced CT abdomen shows an adrenal nodule with HU of 30. Another case, very well encapsulated, but there is a cystic as well as a solid area. This is quite infiltrating tumor that's going to the liver. Relatively heterogeneous left adrenal mass. We have an arterial as well as venous phase in this case. You see a lot of necrosis and then peripheral thick ring of enhancement. So, adrenals are the suprarenal glands, what is commonly called, sits on the either side of the kidney with the arterial supply on either side by at least 3 arteries, superior, middle and inferior adrenal arteries and a draining vein. Histologically, this is one organ where the cortex is very thick and the medulla is very small. And this is how it is on a cross section where you see that the thick cortex has got 3 zones, the zone of globulus, vesiculator and reticularius, which individually will have different hormones that they secrete, which is very important in life. The cortex develops from which composes nearly 70% of the whole adrenal gland is developed from mesoderm, which is very essential to life. That means to say, in the absence of this, life is not possible. On the other hand, the medulla encompasses about 25%, which develops from the epidermis. Not so essential, but then it's very important in terms of managing the sympathetic activity. So each secretes hormone. One is pituitary, the other one is the sympathetic chain, where the medulla catecholamines are excreted from the medulla, whereas the corticosteroids that comes from the adrenal. This is a general outline. If you go to any of the endocrine MDT, they discuss, they have some guidelines, all that. Radiology is part of, imaging is part of the any MDTs, what they discuss. Whether it's terms of initial imaging or to characterize the lesion, to look for the growth or the interval growth pattern, to give guidance to the surgical resection, and then of course the main important part is the follow-up. If we look at the history of the adrenal imaging, if it goes back to 1920s, where air insufflation radiography was performed. The first CT of the adrenal gland was done in the year 1976 with the assessment of macroscopic fat, mainly the myelolipoma, that was done in 1977. In 1991, this magic number of 10HU, the attenuation value of adrenal gland was proposed for differentiating malignant and benign lesions. Further in 1990, there was also parallelly MRI was suggested for dynamic contrast, which were further enhanced by adrenal washout CT techniques, where absolute and relative washout techniques were all described. If you look at the whole adrenal adenomas or the incidentallomas, that's the whole gist of the talk what we are discussing today. The adrenal incidentally detected nodules encompass nearly 75 to 80% of the tumors. We do this on a routine scan for something else and we end up detecting that adrenal nodules. We don't know what to do, and that's what the guidelines are all there for to do this assessment. And of that, of the remaining, there are quite a few other lesions that are detected. Very rarely you get to see adrenal carcinomas. There are different modalities now to assess. CT is one of the main important tool. Of course, MRI has come in a very good way because there is no need for contrast in most of the situations. Nuclear medicine, mainly the PET scan, is then now used quite often because this is one organ where the metastasis happen quite frequently, especially from the lung. Now there are 5 different commonly used radiological diagnostic criteria that is used. Main, this tumor density or the attenuation. We call this as attenuation, and the magic number is 10 that is being given on a non-enhanced contrast CT. And on a contrast enhanced CT, you look at the delayed CT images as well, and you calculate the absolute percentage as well as the relative percentage washout, how the contrast comes. We have the formulas, I'll show in coming slides. So this on the CT. And an MR, the chemical shift imaging, mainly to look at the microscopic fat, not the macroscopic fat, the microscopic. Macroscopic is obviously easily seen. The microscopic fat between the in and out of phase images, which is both qualitative as well as quantitative, which estimates the signal loss on those images. On PET, we have now newer traces that have come up, but most commonly used is the F18 FTG PET imaging. And you also do the assessment of the SUV, which is not very routinely, it's just the eyeballing, not the absolute number that we look at. So adrenal lesions can be benign or malignant, functioning or non-functioning. So these are the things that a radiologist should be done. But in general, the most commonest adrenal is non-functioning benign tumors. So they encompass nearly 75%. Very few will also secrete, where we'll have the secreting adrenal lesions. And of them, what hormone that comes out, we have Cushing syndrome or Cons or adrenal realization, depending on what hormone they secrete. And 20% of adrenal lesions are bilateral. That is something which we have to keep in mind. And again, I said the magic number is 10 HU that has been traditionally been followed for many years, and up to 30% have attenuation values of about 10. So this is where the confusion comes when you see an adrenal nodule on a non-enhanced CT. If the HU is more than 10, what do we do? What do we recommend? That's where the guidance is all about. Now this is the formula that is given. Absolute washout and relative washout. You have a non-enhanced CT and you do a portovenous phase and a delayed phase. Many institutions follow different timelines, 10 minutes and 15 minutes, but ideally it is the 15-minute scan that is very useful to look at the relative and absolute contrast analysis. So these formulas are available anytime. You just do the proper imaging protocol and then you calculate the washout based on that, and you will be able to say whether it's a benign lesion, mainly the fat containing adenomas or not. This is a typical scenario. What you get, you have an unenhanced CT, which I showed in the initial scan, a 13 HU scan, which raised to 80 HU on portovenous phase, and then after a 12-minute delay, there's a drop of the attenuation, the density drops. So this is like 55% of washout. So it fits into the criteria. of relative, and the absolute value is around 66%. This is the classical description for the to calculate the washout and say that it's a adenoma. Similarly, on MRI, we don't have to routinely give the contrast, but what we look at is the microscopic fat that lipid and water presses in and out of phase at different T values. So for 1.5 and 3T there are different values, but what is important is how the signal will drop. Not just the signal drop, you can actually get a quantitative number based on the signal intensity ratio of adrenal to spleen or to the adjacent organs, the liver or the muscle. So again, these formulas are you can usually obtain. If it is for adrenal to spleen, less than 0.7 is the cutoff value for adenoma, and the signal intensity, if you are measuring to the liver and the muscle or the muscle, more than 16.5 is considered as adenoma. Of course, liver, when you have fatty infiltration, you have to include the muscle rather than doing the. There are many pitfalls when somebody has a fatty atrophy of the paraspinal muscles or the adjacent muscle. Again, it becomes a little complicated. But this is how classically it looks like. This is the in-phase image. You see relatively bright or hyperintense lesion on T1 weighted in phase, and on fat suppressed, out of phase image, you definitely see the signal drop. This is the microscopic fat, okay, intracellular lipid which drops. The macroscopic fat that's seen in the retroperitoneum and subcutaneous tissue are all seen. So this is one entity. What we spoke about is, we know that this is definitely benign. But there is a next indeterminate or intermediate adenomas or the nodules, which is the lipid poor adenomas. So this is where the confusion comes, where the HU value is typically between 10 to 30 on a non-enhanced CT. So this is where the confusion starts. If you have to do without giving a contrast, of course MR is helpful in such situations by doing the in and opposed phase to look for the macroscopic fat and do the assessment. On the other hand, there are scenarios where they can look bright on MR, especially when somebody has been given transfusions or super paramagnetic iron oxides, where they can appear bright on T1 weighted images. In the such scenarios, you switch to CT and do a washout technique and do the assessment. Now there is something relative enhancement ratio, RER ratio. This is in a typical day-to-day clinical scenario. You are not doing the assessment for an adrenal lesion, but incidentally you pick up on a CCT abdominal scan for something else. How do we go about? So you take the portovenous phase and do the assessment of relative enhancement ratio with this formula. And anything over and above 210% has got a high sensitivity and specificity to say that for diagnosing the lipid poor adenomas. So this is an example just to show this particular adenoma. The anterior part has got a very low HU, which is 3. Definitely you know that this is fat, but the posterior part, the attenuation value is higher, definitely more than 10. This is an intermediate or indeterminate lesion. So when you give contrast on the portovenous phase, the enhancement is quite significant. From 20, it just raised to 70. So this is what the relative enhancement, which is ratio, which is more and about 250%, and which is definitely diagnostic of cortical adenoma, which you can use this in your clinical practice. And the same thing on an MRI, which shows the signal drop. Now currently this is the guidelines. What I am showing is the European guidelines. This is the Endocrine Society. Unlike any other, most of the times when they make decisions, it's not just one modality or one person who takes this decision. And in radiology, Dr. Anju has been included in this panel. Initially it was in 2016, now the 2023 panel has come out, and she has written a wonderful article in 2017 for the assessment of adrenal incidentalomas, what radiologists should know, what is pertinent to us You can read this article, very nicely written for the beginners. There are many questions in this society to answer, but then two important questions that are important to a radiologist is how to assess the risk of malignancy on imaging and what follow-up is indicated in an incidentalloma if they are not removed surgically. These are two things which are important for radiologists. And when you come, what is the accurate diagnostic imaging is procedure that can be employed. That's one thing that we should know when we are doing the assessment. And the second thing is, can we say it is benign or malignant? And with unilateral and bilateral nodules, what are the recommendations and guidelines we have to give? So they looked at different meta-analysis and papers of at least 37 studies, and they have did. So this is not just the slide for the radiology, but in general, in managing the adrenal incidentalomas, in 2016, they said that there was not strong, good evidence to say that with such a test, yes, we absolutely can say that this is a benign, this is a malignant. In 2023, it's better because they have assessed so many scans. There are some key changes they made, some new major recommendations, not on the radiology side particularly, but in general, how to go about if it is a secretory or a non-secretory, what to do. Can we stick to those HU values on imaging, and what is the size criteria? All those they discussed. I'm not going in general with all the recommendations, but this is a scenario. You know that the top ones are, this is definitely benign, and this is intermediate where the HU value is 16. It's above the magic number, and then slightly higher, which has to be looked at even more suspicion. The lower lesions are definitely heterogeneous, solid. You know that the HU values are definitely more. It has to be further assessed. The whole idea of doing the imaging is like, can we confidently say this is definitely benign, don't worry about it. And what is the rate growth? Do we stop, or do we do the further assessment, or do a biopsy, or look for any other organ? This is the whole thing of the imaging. The first recommendation what they say is, if the imaging is not consistent with the benign lesion on imaging, you have to push this patient to multidisciplinary team. You cannot take the decision. You have to involve the endocrinologist and surgeons, and they will decide further assessment. It need not be just imaging. They'll do the hormonal assessment, and then they'll come to you. So in this panel, they clearly said HU minus 10, no further imaging required. It's end of the story. You don't have to do. And then if it is a homogeneous lesion with HU of 11 to 20, tumor size less than 4, additional imaging and interval imaging of after 12 months is advised, and then further you do follow up based on how it looks like after an interval imaging after a year. If the tumor size is over and above 4 centimeter, but still homogeneous, or homogeneous where the HU value is more than 20, and then the tumor size, even though if it is less than 4 centimeters, or if the tumor is heterogeneous but less than 4 centimeters, what do? It has to be discussed in MDT, and proceed for additional imaging is what has been recommended. And of course, the tumors which are HU of 4, 20 or heterogeneous or more than 4 centimeters obviously has to be discussed. In the follow-up, if the follow-up says that it is uncharacterized or continued to be intermediate, it is stable in size, you further do interval imaging after 6 to 12 months and do the assessment. In case if it is not fitting into any of the criteria, push for the surgery and then do an interval imaging just to assess. Bilateral lesion has to be treated individually. Each nodule has to be characterized individually. We cannot just say one nodule looks so and so, but we have to do the assessment on either sides. So this is the complete flow chart, whether it is potentially malignant or not. Any HU value of less than 10, no further imaging required. Between 11 to 20, less than 4 centimeters, you do an additional imaging or the 12-month follow-up. If it is an indeterminate lesion, you do discuss in the MDT and take the additional imaging protocol, that is enhanced CT or PET CT or even MRI. And if on the other side, if it is a functional and active, you do the hormone assessment, and based on the hormone assessment, you have to do the assessment. There's something called as MAX, which is a mild autonomous cortisol secretion, where there will be secreting, but the symptoms are not overt. These cases are also to be pushed in MDT and then do for the. I just finished. Dr. Sen, Professor Sen sent me this article, which is the latest one, which is published now in Insights of Imaging. Are we done with this washed up? So it's a really interesting article. I think it clearly says that we have to move out of this minus 10 or less than 10 HU values, because we have been following this value, but in clinical practice we know that most of the benign adenomas, fat containing adenomas, HU values will be more, and only 10 to 20% of pheochromocytomas are clinical, though they are clinically silent, but they are they are less than 4 centimeters, usually 2 to 3 centimeters, and they are very aggressive and symptomatic, these patients. So what do we do with these kind of lesions? So there are different guidelines now for the pheochromocytomas as well. If somebody is interested, they can go through. You have to do a proper arterial, venous and delayed phase and look at the enhancement pattern. Similar way, you have to do the imaging on the MR as well. And it is now clearly evident that adrenal washout CT has, with this established relative or absolute washout techniques, they are insufficient in assessing the adrenal nodules. So now with that magic number of minus 30, we are overdoing things, and that's what the whole thing, because most of these cancers, nearly most of these nodules will rarely turn into malignancy. So this is the new thing that has come. Now we are moving out of this minus 10, probably 10 HU, probably 20 HU is the thing that will come up. We are probably looking at one more rats that is coming up with the adrenal nodule assessment, and probably 20 is the new 10, and maybe we have to have further thresholds of between 10 to 20, 20, 40. More studies are required now, as well as the size criteria also. And for the nodule which is threshold of 1.5 centimeters or less than that, maybe the cortisol assessment is not at all required for the clinically silent tumors. Of course, there is a dual energy CT which is very promising, where you see this, you can clearly assess even on the contrast CT whether the microscopic fat is there or not. Nuclear medicine is coming in a big way, depending on what hormones they are secreting. Different traces are available, but most commonly what we are using is the gallium dotonax scan, because most of the pheochromocytomas and other tumors. A tumor like this, which is myelolipoma, macroscopic fat, there is no need. But only thing is, when you see a soft tissue attenuation within that nodule, irrespective of the size, you should always look for a bleeders and do a contrast scan. A benign cyst or neuroblastoma, primary adrenal neuroblastoma, or you see a VHL complex, you don't do further assessment of that particular nodule, but you look for hemangioblastomas and other things. This is a case of lymphoma, adrenal carcinoma. So this turned out to be a schwannoma, primary schwannoma of the adrenal gland, and this is of course looking very heterogeneous, probably either malignancy. When we did PET scan, of course there was a small nodule and the biopsy turned out to be metastasis from the lung. This is the leiomyosarcoma of the adrenal gland, where it probably tumor has arisen from one of the vessels. So with that I end. I think we should move out from this gray zones and probably say what is benign and what is not with this symbol. Thank you.
Thank you, sir, for your valuable insights on the current recommendations. Your talk has given us a clear roadmap for approaching adrenal lesions. As we know, we are a little behind on our schedule. We kindly request our speakers to adhere to the timings. I now invite our chairperson, Dr. Kuparajan, consultant radiologist, KMCH, to join the stage. We welcome you, sir. Next, we have the topic of infiltrative renal lesions, a potpourri by Dr. Neha Bagri. We welcome you on stage, ma'am.
Yeah, thank you so much. So after this delicious lunch, I want to see all of you awake. I know it's a torture, but you must be imagining we had a talk on renal masses in the morning, an excellent talk by Dr. Deva. So why we should listen to renal lesions again? But infiltrative renal lesions are, completely a different spectrum. So I'll be taking you through a lot of cases, not much theory in this lecture. So you see these cases and you analyze why they are different. So how many of you, the residents, are reporting renal masses on CT? Can I please know so that I know what level you are and I can approach in that manner? So please tell me how many of you have reported renal masses yet? Yes, good number of people. So the learning objectives here will be classification more or less, imaging features, what are the challenges, mimics and pitfalls in diagnosis. So this is a broad classification of renal masses. I am not going through this in detail. Renal infiltrative lesions. So renal infiltrative lesions can be malignant and non-malignant, and among the malignant one most common is again RCC with atypical growth pattern, and mostly these RCC have sarcomatoid or rhabdoid differentiation. Second most common is urothelial cell carcinoma, which till date you have been knowing as transitional cell carcinoma. Then renal medullary carcinoma, renal lymphoma and metastasis. Among the non-malignant causes, we have infectious or inflammatory, acute pyelonephritis, xanthogranulomatous pyelonephritis, renal infarction and IgG4 related disease. So this is the all spectrum which we'll be covering now. So what should be your approach when you see a renal infiltrative lesion? First of all, decide the site of origin. The size, shape and contour of the lesion, what is the growth pattern, whether it is ball type or bean type. Mostly among RCC, 94% present as ball type lesions, but still the rest 6% which present as bean type lesions have poor prognosis. The degree of enhancement of the lesion, what is the growth rate and what are other associated findings. So why are these infiltrative renal masses challenges and what is the pitfalls in their diagnosis? So they are usually confined to the renal parenchyma, so they are difficult to detect because they preserve the reniform shape of the kidney. The mass parenchyma interface is poorly visualized. The mass and normal parenchyma may have similar attenuation, so these are the difficulties which you will face. Imaging modalities we have already talked of, so I will skip this one. You have already studied the CT protocol, MR protocol in the morning session. So coming to this renal masses, the growth pattern, the ball type lesion and bean type lesion, what is the basic difference? Ball type lesion enlarged by additive expansion. They present as hump or bulge, as you can see over here. Whereas a bean type lesion, the infiltrative lesion, present as scaffolding of the parenchyma for growth and it enlarges with maintained reniform shape. Then these lesions are best seen in nephrographic phases, and in bean type lesion the pelvic ileal system is encased or obliterated. That is one reason for poor prognosis of these lesions. These are more symptomatic and they have poor clinical outcomes. So this list I have already told you which we will be covering. And this is the prognosis. You can see over here, IRM over here represents infiltrative renal malignancies, and the cancer specific mortality is quite high in infiltrative renal masses as compared to non-infiltrative ones. So this is the classical renal cell carcinoma, the prototype ball shaped lesion seen on ultrasound. You can see a renal mass which is arising from the outer cortex, and this is showing vascularity. So this is the classical ball shaped lesion. The scan of the patient showing a ball shaped lesion on plain scan over here, and you see presence of enhancement. So this is a classical clear cell type RCC. Then why do you say that the prognosis is good as compared to infiltrative lesions? Because you see these tumors are confined to the cortex. They are not infiltrating the pelvic ileal system. Their surgical excision is quite simple. Even these cases which are confined to the poles, the surgeon can go ahead with partial nephrectomy in certain cases which are limited to the kidney. And then these are not infiltrating the pelvic ileal system. So this is why the ball type prototype lesion has a much better prognosis than the infiltrative type RCC. So coming to the infiltrative type, they comprise about 5% of the conventional RCC. They are aggressive, hypervascular. The renal contour is maintained. They alter the internal architecture of the kidney, and they are the prime differential diagnosis for infiltrative renal neoplasm. So if you see an infiltrative renal lesion, first think of infiltrative RCC, then urothelial cell carcinoma, because again incidence wise RCC is more common. So coming to these cases, here on ultrasound you see there is a heteroechoic mass which is completely infiltrating the kidney. It is vascular on color Doppler imaging, and CT scan of the patient shows again a infiltrative mass with a small exophytic component as well. But in these cases, as you see, it is infiltrating the pelvic ileal system badly. It is not possible to partially excise them. Nephrectomy is the only option, but these cases do metastasize very early, because as I told you, they have a component of sarcomatoid or rhabdoid differentiation on histopathology. So they have poor clinical outcomes. Another case here, you see an infiltrative mass in the right kidney which is extending from the renal vein till the IVC over here, and it is infiltrating the pelvic ileal system. So whole of the kidney more or less is completely occupied by the mass with a preserved reniform shape, but extension of the tumor thrombus by the renal vein into the IVC, and you can clearly see the infiltration of pelvic ileal system. Even in the delayed scan you can see the calyces are completely occupied by the mass. So these masses have bad prognosis. Another case over here, you can see presence of liver metastasis, multiple hypodense lesions in the liver parenchyma, and as you move down, another liver metastasis, so multiple liver lesions, and right kidney shows up a lesion which you will see gradually shows a infiltrative pattern. So with more or less preserved renal contour, the renal mass is occupying the mid and lower pole with infiltration of the pelvic ileal system. So this is another way how a renal mass can present, predominantly cystic, infiltrating the kidney. So in approximately 25% of RCCs, they can present as predominantly cystic pattern, and 15% of them showing gross calcification. So over here you can see multiple peripheral calcifications and a large cystic infiltrative mass completely infiltrating the right kidney, left kidney, but you can see the solid component over here. This solid component on this lateral and inferior and posterior aspect is showing enhancement. So this is again a atypical RCC. So another one, presence of calcifications on plain scan, you can say gross chunky calcifications. So calcifications do not rule out malignancy, they rather favor RCC in a mass. So this is how they can present in a calcified way. Then multifocal RCC, these infiltrative masses usually are highly aggressive. In such cases, you should not have a satisfaction of search. You see one mass and you say, okay, I'm done. No, look for another lesion in the same kidney. In bilateral kidneys, you might find another lesion like this at the lower pole, and in another kidney as well. Some syndromic association, do look out for them. So here you can see another aggressive mass from the posterior cortex of the right kidney, which is so aggressive it is infiltrating the posterior muscle, the psoas muscle, with a necrotic component inside, and this is how it is extending from the kidney through the xerotars fascia into the muscle. So this is like T4 stage. So this is another large mass arising from the left kidney, which is quite large, aggressive as it looks on plane itself. On post contrast, you can see it is heterogeneous, necrotic, completely infiltrating the left kidney with extension into the renal vein, IVC, and multiple lymph nodes. So this is how on cross-sectional imaging you must explain the mediolateral extension of the mass as well as the craniocaudal extension of the mass with complete description about the lymph node, the vessels, the metastasis, and the bones. So here you can see presence of multiple liver metastasis again in a infiltrative RCC. So this is again to re-emphasize, please do look out for metastasis in these cases very carefully. Presence of lung metastasis with an infiltrative right renal mass. So RCC in horseshoe kidney, what is different about it? The prognosis is unaffected by the anomaly. The prognosis depends on tumor pathology and stage of diagnosis, and they can present as infiltrative masses as in this case. So their vascular supply can be variable and there can be anomalies of collecting system associated. Renal medullary carcinoma. So this is a rare aggressive subtype and it usually occurs in young male blacks of African ethnicity. This is very strongly associated with renal medullary carcinoma. Young black male, African ethnicity, sickle cell trait. And tumor most commonly involves the right kidney. And they usually have metastasis at initial presentation and poor prognosis. Coming to urothelial cell carcinoma, which is the second most common in the infiltrative category, and the prototype is bean type with epicenter in the collecting system. So here 90% of the tumors arise from the renal pelvic urothelium. You can see thickening of the renal pelvis over here, and this is the delayed scan showing that the pelvic ileal system is infiltrated by the mass, and these usually show early lymphatic metastasis as compared to RCC, in which hematogenous mets are more common. These usually enhance less as compared to the renal cell carcinoma. So a central mass like this in the renal pelvis now needs to be differentiated whether it is RCC or urothelial cell carcinoma. Why? Because a central located RCC, the management would be nephrectomy, whereas in cases of intrarenal urothelial cell carcinoma, it will be nephrouretrectomy plus lymphadenectomy. So the management is different. So this you need to differentiate on the basis of enhancement pattern and plus looking for multifocality. So usually urothelial cell carcinoma shows presence of multiple lesions along the urinary tract. So here you can see a large calcified mass completely infiltrating the kidney. There is a large bulky lymph nodes and presence of another lesion in the lower ureter, VUJ, and extending up to the bladder mass. So this bladder wall. So this multifocality does favor the possibility of urothelial cell carcinoma. Lymphoma, another presentation can be an infiltrative mass. So most common is a solitary mass, multifocal masses, but diffuse infiltration, secondary infiltration by the retroperitoneal nodes, and perinephric soft tissue secondarily infiltrating the kidney. So this is a case, you can see both the kidneys are grossly enlarged, and on contrast enhanced CT, these are predominantly hypodense lesions completely infiltrating both the kidneys with associated retroperitoneal lymph nodes, which you can see over here encasing the vessels. So this is renal lymphoma. So you can see both kidneys enlarged in presence of lymph nodes. So another case, perinephric soft tissue secondarily infiltrating the left kidney along with presence of nodal mass. So this is another form of presentation of renal lymphoma. So this is how you should describe the mediolateral extent of the mass very clearly for the surgeon and associated lymph nodes. Another thing over here, the perinephric soft tissue, the predominant presentation with secondary infiltration of the kidney. This is one presentation of lymphoma. So this I showed you, this is another case, bilateral kidneys enlarged, diffuse infiltration, but what is different? There is presence of mediastinal lymph node, there is presence of axillary lymph nodes, and there is presence of hepatosplenomegaly. So this is again lymphoma. So here you can see presence of bulky retroperitoneal lymph nodes with infiltration of both the kidneys, but this was a case of leukemia secondarily involving the kidneys. So nephroblastomatosis can be an infiltrative presentation in children. So this is how it can present as multifocal masses in both the kidneys. So this is a 9-month-old girl with palpable abdominal masses, and you can see multiple hypodense lesions in both the kidneys. So this is nephroblastomatosis, which is a precursor of Wilms tumor. Rhabdoid tumor of kidney, it is found in children, and it usually is a very aggressive lesion, and it presents as an infiltrative mass completely destroying the kidney. And in this case you can see extension of this tumor into the spinal canal through the neural foramina at multiple levels, and inferiorly you will see its infiltration into the muscle as well. So these tumors are again very aggressive, so that is why in adult infiltrative RCCs rhabdoid differentiation is usually found on histopathology. Renal mets, though rare but can be seen, and they usually present as multiple focal lesions but can present as small infiltrative lesions. So this is a case of metastasis from testicular carcinoma, and here you can see this nodal mass which is secondarily extending into the kidney. This is another presentation of renal metastasis. So this is a rare histopathology, so sometimes we are stuck being all these diagnoses still there. Such histopathologists can turn up like PNET or extraskeletal Ewings, nothing prototype for them, but just to complete the list, these can also occur as infiltrative masses. So now coming to non-malignant ones, vascular anomalies, renal hemangiomas, they can occur as solitary focal mass or diffuse infiltrative process. Here in this case you can see this enhancing lesion in the renal pelvis, and they will show persistent enhancement in the delayed phases. Another renal lymphangiectasia, dilatation of perirenal and infrarenal lymphatics, they might have some familial association. These are perinephric fluid attenuation of 0 to 10 HU, and no other renal pathology is usually associated. So this was a young male who presented to us with this incidental finding on ultrasound abdomen and CT showing dilatation, multiple fluid filled areas in the kidney as well as completely infiltrating the left kidney, and this was renal lymphangioma. So renal pseudotumors, they can be developmental like prominent columns of Burton. So these are usually enlargement of the renal cortex which is projecting in the renal pyramids, and this appear like a pseudo lesion and can be very clearly differentiated because it will enhance like cortex in all the phases, and on ultrasound it is beautifully seen continuing with the renal cortex. Pyelonephritis or nephronia can sometimes mimic a infiltrative mass lesion which is abscess in formation. You can see here hypoattenuating ill-defined lesion in the anterior cortex of right kidney, and which is being shown in this sagittal as well as coronal images. In these cases, the patient's clinical history is very, very important. A patient presenting to you with flank pain, fever and such lesion, and there is perinephric stranding, there is minimal thickening of the fascia, you should think of nephronia, absence in formation, and follow up these patients. Renal tuberculosis, again a very significant diagnostic dilemma in certain cases. This is a classical case on NCCT. You see multiple hypodense areas, multiple areas of calcification around the calyces, and you can see cutoff of the calyces and thickening along the pelvis and the upper ureter. So this is the typical presentation of renal tuberculosis. So you appreciate the calcification, the hypodense areas, and this is an early phase. So in this case, what you see on plane, there are again renal calcification. There are hypodense areas, there is abnormal cutoff of calyces, and you can see this calcification persistent. So this was a HIV positive young male, 21-year male, presenting with this picture. So this was genitourinary tuberculosis. There are associated lymph nodes as well. Another case, here you can see this thickening along the upper ureter which is extending till the pelvis and stranding, and you can see this heterogeneous attenuation at the lower pole with associated perinephric stranding. So this was again renal tuberculosis. Now this is an elderly female who came for MRI LS spine and for low backache. So what do you see? The backache was due to the renal infection. She had a bad infection in her right kidney. The kidney is small and the calyceal system was distended with pus, and even so moreover there was a breach in the cortex and this collection was extending till the psoas. So always keep your eyes open. For any diagnostic modality, please look at all the organs which you can see, and she had an incidental cystadenoma in the ovary as well. So xanthogranulomatous pyelonephritis, what is the classical feature? Presence of a staghorn cal in the renal pelvis with associated enlarged kidney, heterogeneous attenuation, presence of fat, formation of xanthomas, that is xanthogranulomatous pyelonephritis. So don't confuse it with malignancy. These are the classical features. I will show you a few more cases. This is an early one. You can see a cal in the pelvis. There is heterogeneous attenuation, but there are small fatty areas as well. So this is an early presentation of xanthogranulomatous. And another one which is very advanced, you can see the left kidney is completely finished. There is no left renal parenchyma which is residual over here. This staghorn cal, and what is seen, very, very rare from the diaphragm, pleuro, pulmonary fistula, renocutaneous fistula. So these are complications of xanthogranulomatous pyelonephritis, never seen in any malignant mass. So you have to look for these findings. Renal infarct, the kidney will not enhance at all. There will be complete disruption of the renal artery. This was a case of trauma. So there is no way you can confuse it with a mass, but it can be a mimicker in certain situations. So the kidney is not at all enhancing. Vascular malformations, what you will see, enhancing renal mass, same attenuation as vasculature. There will be enlargement of feeding renal artery and vein. You can see these clusters of vessels over here. So this is renal vascular malformation. Then this is a renal aneurysm which is ruptured and formed a hematoma. So these things which Dr. Deva also showed in the morning, you can take help of MRI to look for hemorrhage, but in this case, it is clear cut hyperattenuating on plane. So you can see this is hemorrhage and follow up this patient's. IgG4 related kidney disease can be sometimes difficult to diagnose. It can present as bilateral infiltrative lesions in the kidneys or as just simple infiltration throughout. Plus, you can see in this case, this is from a journal, you can see infiltration into the kidneys, liver and small patchy infiltrates in the lungs. So this can be a very close mimicker of malignancy, and these are usually diagnosed on histopath only. So this is the reporting format. What you should report: mass size, just one more slide, I'm concluding. Mass size, type, enhancement, presence of an infiltrative growth pattern, fat, vascular or collecting system invasion, extrarenal spread, presence of lymphadenopathy, number and location of renal arteries and veins, visceral metastasis and the stage. So to conclude, infiltrative renal malignancies are more aggressive, worse prognosis. Other causes of infiltrative lesions can be infectious, vascular, autoimmune. Correlate the imaging findings with history and lab results, and radiologists should carefully consider the mimickers to avoid unnecessary surgery. Thank you all.
It is very evident that a nuanced approach to renal lesions comes with experience, and we thank you for sharing your ears with us in such a practical way. Thank you, ma'am. Next, I invite Dr. Saugata Sen on stage to discuss the topic on bladder lesions, a mixed bag.
I do not know how many of you do urology, but I have a very great experience with bladder cancers. So one of my close relatives developed bladder cancer in the year 1986. I was a student then in school, and I remember my relatives, other relatives, uncles and all going from center to center asking whether the slides had muscle invasion or not. So muscle invasion was a big thing then, whether the tumor had infiltrated the muscle or not. And one center would say yes, muscle invasion, other center would say no, muscle invasion, and confusion would go on. 12 years, I became a doctor, and then I joined urology to do some urosurgery. I was a house staff then, and I did a lot of transurethral dissections, nephrectomies and so on. But I was the junior most guy. So they asked me, go with the slides to the pathologist and find out, is there muscle invasion or not? I used to do the same thing over and over again for every case. Go on another 25 years, 2025, when I ask my colleagues who go to the urology MDT, what do the surgeons ask? They say muscle invasion or not. And if you understood in radiology whether there is muscle invasion or not, you do not need to sit here for the next 20 minutes. It's the one thing that is required in bladder cancer. But I'll go on and show you a few more cases. It's a very basic talk, and you don't need to take pictures. You can just mail me, I'll send you the PPTs. So the first set of slides are how does a bladder tumor look like on CT. And we mostly do CT, ultrasound and CT, very little MR. So if you have a lesion like this at the dome of the bladder, which is going along like this, is generally an adenocarcinoma from an urachus, that is the patent vital intestinal duct. And here is the patent urachus. You can see the cancer can happen anywhere in the tract. So if you have a lesion somewhere around there, it's generally a adenocarcinoma from the urachus. You can have squamous cell carcinomas from calculus disease in the bladder. So large calculus over here, a lot of proliferation and enhancement in the mass. So those are generally squamous cell carcinomas. Even in the renal pelvis, if you have calculus, they will give rise to squamous cell carcinomas, though it's not too common. You have also schistosoma-associated squamous cell carcinomas. This is not very common in our country. The eggs are over here, and generally around the egg, the tumor develops. So not very common, you won't see them in our country. It's mainly a Mediterranean disease. But generally, the most common is transitional cell carcinoma, and they usually appear in various forms. The morphology is it varies a lot, and it's important that you pay attention and see everything along the entire urinary tract, which means from the renal pelvis to the prostatic urethra, everything literally is transitional cell mucosa, and tumors can happen anywhere. So you have this as a solitary polypoidal lesion in the bladder. The next is another solid polypoidal lesion with a broader base. So the base is pretty broad over there. There's possibly perivesical extension of the tumor, which is very important, which is one of the questions in the tumor board. And here you can see a plaque-like broad-based lesion in the dome and the left lateral wall of the urinary bladder. Also here, there is very high chance that the lesion has gone out of the bladder. So that's a perivesical infiltration. Here's a lesion which is inside the urinary bladder diverticulum. It's a polypoidal lesion which is developed within a diverticulum from the urinary bladder. And here's another lesion which is kind of plaque-like, enhancing and multifocal. So you can see the involvement is probably all over the bladder, and the urologist really has a hard time to take out everything. Oftentimes these are infiltrating into the muscle and out of the bladder, so a radical surgical option is curative for the patient, or that's offered to the patient. Here is another case where you have a large lesion in the bladder which has obstructed the ureter. There is hydronephrosis, and there is rupture of the calyces with contrast extravasation around the left kidney. Now, how do you do these scans? When you do a CT scan, how do you do? You usually take a 60-second scan, and then you take a 5-minute scan, which is the delayed scan. The bladder tumor detection rate is better in the urothelial phases, which is the 60-second scan, that is almost 90%. And much lesser it is in the excretory phase, because the contrast obscures the tumor. So over here, the contrast has obscured the tumor, which is the delayed phase. Here's the around 60-second scan, where you can see the enhancing lesion in the bladder. So urinary bladder neoplasms are of 3 types generally: carcinomas, that is TCC, adenocarcinoma, squamous cell carcinoma. TCC is generally most common. There are rarer tumors. These are very rare tumors. You might not find them in your practice very often. I've just found one pheochromocytoma. I've not found any of them. If you want to have a better read, this is an article from AJR which you can go and see. Now, what are the differentials of a tumor in the urinary bladder? Generally a blood clot. Oftentimes you will have blood clots or hematuria in the bladder because of various reasons. Infection, sometimes some drug induced, a lot of chemotherapies cause, cyclophosphamide for example, cause hematuria, and they may form clots. You may think that they are a tumor, but contrast, this is contrast. This is the enhancing lesion, and you have the tumor separately visualized over there. So contrast CT helps in diagnosing, differentiating a tumor from a clot. Now, what about treatment? How do you manage these cases? So there's a gamut of options for TCC of the urinary bladder. Generally, surgery is the procedure of choice. You can have a conservative surgery like a TUR, endoscopic surgery or endourology, or you can have a radical approach which has open surgery, laparoscopic or robotic. Any of them. Apart from them, there is intravesical therapy, chemotherapy, immunotherapy, and radiation, which are all, supportive therapy for the surgeon. So generally, if you have a tumor which is a little more aggressive, you've done a TUR, you might add intravesical BCG after a few months, or chemotherapy, which is instilled inside the bladder, like a mitomycin. So these things are done. So this is how the treatment is offered to the patient for TCC bladder. Now, what does the surgeon want to know? There's several questions apart from perivesical spread. Over here, if you see, the tumor is infiltrating on one wall which has gone outside the bladder, but also is involving the left ureteric junction, the VU junction on the left side. Here's another case where you see that the polypoidal lesion has very small attachment to the bladder wall. There is nothing which has gone outside the bladder. So this patient would probably undergo a conservative approach, a TUR-based resection. Here is another case which is multifocal. You see all the arrows are given. You have a lesion in the ureter, you have a lesion in the bladder, you have a lesion in the pelvis. Here is another lesion in the renal pelvis and also in the urinary bladder. So what happens is the entire transitional cell epithelium undergoes an oncogenic change. It's very much like the oral cancer. In oral cancer you will sometimes find a lesion here, it's treated, then another lesion develops in some other place. Bladders are like that. And oftentimes when you have a tumor over here, so renal pelvis, the entire ureter you have to take out during surgery with a cuff of bladder, with lymphadenectomy. So that is the rationale behind such an aggressive surgery, that the entire transitional cell epithelium undergoes a field change. Here's another case where you can see that over here the left ureter is involved. It's going along the left ureter from the bladder. Over here, the trigone is involved. So what's the trigone? Trigone is on a triangular area in the bladder, on two sides of which the ureters insert. So here's one side of the trigone. You can see that the tumor has arisen from here. It's multifocal. It's gone on to the other side as well. And in this case, the lesion has gone outside the bladder to involve the seminal vesicles. So what does the surgeon want to know? These are the things that the surgeon wants to know. Of course, perivesical spread, UV junction involvement, trigone involvement, multicentricity, whether prostatic urethra is involved, prostate is involved, seminal vesicle is involved. Apart from that, nodal status and other metastasis, which we will not discuss. Now, how to differentiate a bladder which has undergone TURBT from tumor recurrence? Oftentimes, when you have a bladder which has undergone TURBT, the walls become very edematous. So here you are. You have a tumor over here which underwent the first surgery, which was TUR and resection of as much tumor as possible in the bladder. And then on follow-up, you can see there is a lot of edema in the wall, and we really do not know whether there is tumor developing or not. With experience, you might say, of course, this is TURBT change, but to be very sure, you can do MR, you can do a T2 as well as the diffusion, and if you have no, in the higher B values, if you are not seeing any bright signal on the bladder wall, it's unlikely that you have a tumor. So this is one technique by which you can differentiate. You can also have post-treatment changes, which is a very important part of radiology. Also for intervention. So here is a case where the anterior bladder wall has perforated after TUR. It's not too uncommon because surgeons are very aggressive trying to get out as much tissue as possible so that on the tissue they can say whether on the tissue is good enough to involve the detrusor muscle so that muscle invasion can be seen. So sometimes these changes happen. Here is another case where there is a perforation of the urinary bladder. And here there is an IEL conduit which is being performed as radical surgery for bladder cancer, which was muscle invasive. You can see there is an urinoma formation, so there is probably a leak. You can see extravasation of contrast. And in these cases, sometimes you can put in infant feeding tubes so that this urinoma is made dry. There is no more leakage, and the urinoma or the leak can heal on its own. Post BCG installation, you can have cystitis. It's very difficult to diagnose, but you are doing a TUR. You are damaging the mucosa, and mucosa is the immunological barrier for any infection or any pathology in the bladder. If that has not healed well, there is possibility that cystitis because of the tubercular bacillus contained in the BCG may happen. So you can have cystitis of the urinary bladder. You can also have, so this is a prostate which is normal before treatment, and in these three, you can see that this is post-BCG prostatitis. Very difficult to treat, very difficult condition for the patient, takes a very long time to heal, but these do happen. So muscle invasive versus non-muscle invasive, so that is the last and key question. I have some time, so I'll go a little slow. If you have TCC, there are just two types. One is non-muscle invasive. In non-muscle invasive, you have a conservative approach. So conservative approach meaning that you do not do a radical surgery, you can conserve the bladder. So you do TUR and you do other therapies like BCG or intravesical installation of chemotherapy, and you follow. So this is the protocol for non-muscle invasive bladder cancer. If it's muscle invasive, there is always a radical approach ultimately where you have to take the bladder out and you have to create an ileal conduit or otherwise. So these are the two basic ones. It's very simplified. There are more nuances to it. But this is the basic difference in treatment of non-muscle invasive and muscle invasive bladder cancer. So when you do TURBT, a lot of times if the surgeon is not aggressive enough and you do not have detrusor muscle in your sample, 30%, that's some of the papers which say that 30% is understaged. And then that means there is a 30% increase in 5-year mortality, which is a huge number, which is why radiology comes in to find out whether there is muscle invasion or not. And if you have to find out muscle invasion, what do? You can look at VIRADs. Now I never knew VIRADs. I don't practice VIRADs, so I started looking at VIRADs today at 3 o'clock in the morning. It's very simple. What you have to do is based on MR, and it's got 3 sequences. You have a T2, a diffusion weighted imaging, and a contrast sequence. Now, in practice, most of you will not be using MR. Most of us use CT for characterization, for staging of bladder cancer. Now, when do you use MR? For our institution, we use MR mainly when we cannot use contrast. So there's creatinine is high, patient is allergic, etc. In these cases, we use MR for assessment of bladder tumors. And then only these 2 sequences are important, T2 and diffusion weighted imaging.
And in these sequences, what we try and find out, location morphology and integrity of the muscle wall, whether the muscle wall is infiltrated or not. Now, if you see this, schematic, you will understand that V4 and V5 are very easy to diagnose. So V4 and V5 is very simple, it's gone outside the bladder wall, and V4 is involving the bladder wall. V1 and V2 are also easy to diagnose because you can see a uninterrupted low signal intensity between the tumor and the bladder wall. Same here. V2 is also same signal intensity, that is uninterrupted low signal intensity between the tumor and the bladder wall. The difference being this is less than 1 centimeter and this is more than 1 centimeter. So these two are basically same except for the dimensions, less and more than 1 centimeter. 4 and 5 are very simple and easy to remember. 5 has gone outside the bladder wall and 4 is involving the bladder wall but has not gone outside. The problem always is with the 3. And here is the disappearance of category 2 findings but no clear disruption of the low signal intensity muscularis area. So this is a really problematic area. So in the bladder there are basic 3 layers. One is the mucosa, one is the submucosa muscularis and the other is the muscle. You have to find out whether lesion has involved the muscle or the lesion has not involved the muscle and there is integrity of this uninterrupted low signal intensity line. So let me show you one or two cases. So before we go, this is how it is. Is the muscle layer intact? No, 4 and 5. If the muscle layer is intact, generally 1 and 2 and 3 is the one where there is a controversy. Okay, so let's see what happens here. So this is a small lesion, this is less than 1 centimeter. This is a Weyer's 1 lesion. Why? Because you have the lesion which is small and you can see the high intensity area which is not involving the muscle. So let's go back and see. What is one? Uninterrupted low signal intensity line representing muscular integrity that has to be intact and less than 1 centimeter. So here you are, less than 1 centimeter. And the line is intact. So if you see the schematic, you will see there is a white line which is intact in the schematics, so which is present over there. Go to the next one. This is the same, except this is a larger tumor. This is more than 1 centimeter, and is in the contrast. You can very well see that the muscle is spared. This is the same one with the diffusion weighted images. If you go to Weyer's 3, this is a problematic case. Here you can see that the muscle layer does not have the tumor. The tumor signal is not present in the muscle layer. It's more than 2 centimeters, but it's clearly very adherent to the muscle layer. So this is where we are not sure whether the muscle is involved or not. Let's be very clear, we are not sure muscle is involved or not. The last 2 cases, Weyer's 1 and 2, we were sure muscle is not involved. We come to Weyer's 4, we know the muscle is involved very clearly. It may or may not have gone outside. The diffusion shows that it's not probably gone outside. And Weyer's 5 is very simple. So this is another Weyer's 4 or 5 probably. Here's another one which has really gone outside the bladder wall. And so it's gone into the extrasacral fat. So 4 and 5 are very clear. Muscle involved or gone outside. 1 and 2 are very clear. Muscle is not involved. The 3 is the one which is a problem. So here is another case where you can see the tumor. You can see the tumor over here and you can see there is a thin line around it. You can see a thin line around over here. We do not know, we are not too sure whether the muscle is involved or not. So our job in Weyer's is basically to find out the 3. 4 and 5 is easy to diagnose, 1 and 2 is easy to diagnose. And if you can diagnose 3 confidently, this gives confidence to the surgeon that the tumor is probably not involved in the muscle. So this is all about Weyer's. If you can practice it, great. I'll come to my last slide, I'll finish up fast. This is what we discussed. We discussed bladder neoplasms, the different types of carcinomas, the type TCC adenocarcinoma, squamous cell carcinoma. We also discussed diagnosis, follow-up. We discussed complications of management, recurrence, management of complications, which is more of intervention. I showed just one slide, and also Weyer's. So very grateful that you come here. Thank you very much. Thank you very much indeed.
Thank you, sir, for giving us a fascinating insight into how to approach to such a diverse range of cases. We now move to the discussion session.
Any questions from the audience?
Good presentation. I missed the first one, but the last two, the lecture was excellent. I'm a urologist, only surgeon here. I think the rest are the radiologist. I think as the last speaker said, we always ask, is there a muscle invasion? Is there a muscle invasion? I think that's the most important factor determines the decision what we're going to do. As he clearly explained, if there is a muscle invasion, that bladder has to come out most of the time, even though nowadays we are also trying a bladder preservation treatment even in a muscle invasion. But if there is no muscle invasion, then obviously the conservative treatment. But here, I think that more often we use that MRI, we don't decide the treatment based on the radiological report. We need a histological proof. Even if you say there is a T2 or a muscle invasion, if it is obviously T4, yes, we consider we can take the bladder out. But if it's like a Virat's 3 lesion, we can't do an invasive treatment like a radical cystectomy based on the MRI report alone, where we contemplate always a relook biopsy. So the often where we use that MRI is post TURBT. If the report comes as a T1, he said 30%, in fact 30 to 40% actually it is a downstage. So what the recommendations say from our urology forum is to go back and do a relook biopsy. But doing a relook biopsy is an invasive procedure that patient has to wait for 6 weeks. In that period, prior to doing that biopsy, we always get an MRI. If the MRI says no tumor, then we skip the relook biopsy. If there is a suspicion, then we do a biopsy. That's my comment about that muscle invasion. Thank you. The cystoscopy and biopsy. And I think it's very well covered from the bladder side. I think all the point that ureteric involvement, that's a single prognostic factor. If there is a ureteric involvement, it comes out with the worst outcome. So I think it's a very well covered from my side. If any doubts or question from the audience? And Trigon is also considered as a bad prognostic factor because that's the fixed part of the bladder. The rest, the whole bladder expand and shrink, but the Trigon is a fixed part. It's an extension of the ureteric end. And the size also important. The bladder tumor size also important. I think it's again if the URTC timetable, URTC, the risk category, we use it for a superficial bladder tumor. I think we categorize the bladder tumor into low risk, intermediate risk, and high risk. On that the size is the most important factor. So if you give accurate size, I think it does help in terms of prognosticating superficial bladder tumor. Any doubt? I mean, please.
Give the mic. Give her a mic.
I'm Dr. Vandana. I would want to know from the urologist present here, if you have a smaller tumor, say a T2 tumor, but you see a node which is say around 1.5 centimeter in the vicinity. Now what do you do? Node.
I think the current recommendation for a muscle invasive bladder, irrespective of nodal status, we have to give a neoadjuvant chemotherapy followed by surgery. So if there is a node, I think I think it's we have to know it is a reactive node or a metastatic
Yeah, so
node.
that is the-
Then we do a PET CT. The PET CT is more accurate in terms of assessing the metastasis, not the local. Obviously, the plain CT, I mean the contrast CT and MRI is more than sufficient. But to look for other places like regional or systemic metastasis, we always use a PET CT.
There are certain areas, sometimes it's very difficult for me to tell you that this node is suspicious or not, those gray areas. So how do you suggest that we should follow that? You cannot wait for this long, or do you want to wait for this long for the node, to say that it's that gray area which how do you tackle that gray
I think
area?
if you ask me radiologically to diagnose, I think your senior colleagues has to answer how, what are the factors they consider it's a node is a malignant node or a normal node.
So the issue is that the node is also positive.
Positive.
If the node is positive on PET also, but it doesn't still come under the size criteria. Sometimes the size does not match, sometimes the SUV does not match, because in a bladder SUV is taken as a delayed SUV, not immediate SUV. So that's what I'm trying to ask. Sometimes those gray areas, how do you handle that gray area is what I would want to know. That's a diagnostic dilemma for me also, because I have to give the answer to the urologist who's asking me. So I'm just looking for a
I think if you have done a PET CT, irrespective of the size, if there is on the PET CT, it considered metastatic.
Okay, so you will
Okay,
take it.
so not always. There is a, I have come across one patient who had a bladder tumor, TURBT done. It was only T1, multiple nodes, but was not the pelvic node, paratic nodes, thought to be metastatic. But when we reviewed in tumor board, they said the primary histology and the nodal status is not matching. Why not you go and do the biopsy? So I did the biopsy of the node that came back as a TB. So, I mean, that's a rare exception.
Yes,
But
so-
in general, if you see a regional node, it has to be very, very suspicious.
Okay,
Thank
thank you.
Thank you, sir, for that enlightening discussion.
Yeah. Sir, I have a doubt from Sain sir. Sir, about that Virets 3 and Virets 2, why do we have that dilemma, that why that hyperintense line? Can't we just say that what we do in other extensions, how do we describe the other extensions? Like if there's a breach in that hyperintense layer, we say it's a Virets 4, and why not, if it's not extending it and there's not a break in that hyperintense layer, why can't we say it's just Virets 2? Why that doubt we have about that hyperintense layer?
See, it's about the probability. How certain are you? You're never 100%. So when you think, you have to think in probabilities. So and always the bladder's optimum distension you will not get. So when you have these things, then you will think in probabilities. You will think that, okay, in 60-70% of cases, this should be Virats 2, the rest, Virats 2 or the rest Virats 3. In these cases, we would always overcall, because that's the life of the patient. About the nodes, the prostate and the bladder always have small nodes. They are never very large. And if you have the tumor histology, if it's poorly differentiated or moderately differentiated, we would call them positive generally. And if it's bladder muscle involvement, there's a difference between T2A's probability of node and T2B's probability of node. But again, it's all in probabilities. You can never be 100%, so we'll have to say, in my opinion, 90% chance that this is a pathological node. That's how it is.
In that first lecture, in terms of infiltrative lesion, I think infiltrative lesion, if you diagnose radiologically, it is infiltrative. But if you see that other description, I don't know how confidently you can say it is a non-infiltrative, because the well circumscribed tumor also infiltrate the vein. It does spread. So I don't know where you stand. I think if it's infiltrative, if it's non-infiltrative, it doesn't mean it is a non-infiltrative. And that's one as a clinician from my side.
I think in that scenario only the renal morphometry scoring will help. That's.
See, most of radiology, positive predictive value is very good. It's the negative predictive value where we suffer. So when you say infiltrative, surely infiltrative. When it's not, we're not too sure. So any study which has very high negative predictive value for radiology is a very good study. It's always like that.